excited to have Dr. Nicholas here today. She's a nephrologist and she's a specialist in hypertension, and she's a professor at UCLA. And she's got an MD, PhD, and a master's in public health. You went to school a lot. Thank you. She is nationally recognized across the country in research in kidney care, and I see her at a lot of meetings, always learning new things, which is important because they got to learn too, just like us. Dr. Nicholas is passionate about improving outcomes for people with diabetes and kidney disease, especially in underserved communities. She's won multiple prestigious awards, published over 120 scientific works, and continues to lead groundbreaking research using machine learning to tackle kidney disease. It's my pleasure to welcome Dr. Susan Nicholas to present Diabetes and Blood Pressure Tips and Tools for Keeping It in Check. Please welcome Dr. Nicholas.
Hi, Laurie. It's so wonderful to have this opportunity to talk to you and all of your friends here today. You know, you guys, I've known Laurie, gosh, Laurie, I've forgotten how long I've known you, but it's been many, many, many years. And she's so right that pretty much every conference, kidney conference that I attend, Laurie's always there. So it's such a wonderful thing to see the work that you've been doing with the Renal Support Network. I fully support this effort, and it's really a pleasure and an honor for me to talk to you today about this topic. So I'm going to open up my slides and share my slides, and then we'll get started. Oops, not this one. This always happens just when you have your slides ready. Okay, it's time to pull them up. They disappear. Okay, here we are. Let me put that in presentation mode. All right. Let me know if you could see my slides. And so since the slides are in presentation mode, if there are questions in the chat, I won't be able to see them. So just go ahead and stop me for any questions, but there should be time at the end for a discussion as well. So as I mentioned, I'm really pleased to have this chance to talk to you about diabetes and blood pressure and to provide some tips and tools for keeping it in check. You've heard a little bit about me. I am a tenured professor of medicine. I am a hypertension specialist, but I also work in the area of diabetic kidney disease, particularly looking at the causes mechanistically and in drug development to help delay and to prevent diabetic kidney disease from happening. I'm currently serving as the interim academic chief for nephrology within UCLA. So the objectives for today, I think one of the important things is, and this audience is sort of an advanced audience, but I think it's always important to go back and revamp and understand some of the underlying things that lead to kidney disease as a result of either diabetes or high blood pressure. And there are some individuals in the audience who have not had kidney failure, have not on dialysis or kidney transplantation. So I think this type of information is also going to be very important for you. And I'm hoping that you can share some of this information with your friends and colleagues in terms of preventing the development of kidney disease and in managing diabetes and high blood pressure. So that's where we'll talk about why should we care. And then we'll talk about information on signs and symptoms and the diagnosis and complications of high blood pressure. And then at the end, the rest of the talk, we'll discuss some simple, effective ways to manage diabetes and high blood pressure to protect your health. And that's regardless of where you are. So why should we even care? Well, in the United States, about almost 40 million individuals or adults have diabetes. And 50% of US adults have high blood pressure. About 2/3 of those individuals who have diabetes also have high blood pressure. So clearly they coincide and they coexist. But I think the important thing here, and many of you are aware of this, is that both of these conditions are associated with serious complications. And the way that it occurs is that you have high blood sugar or glucose and high blood pressure damaging your blood vessels. And together, they then increase the risk for stroke, heart attack, vision loss, and of course, kidney failure. We'll talk a little bit about that. And diabetes and high blood pressure, one of the reasons why we're talking about is because they are the two most common causes of chronic kidney disease and kidney failure. So, what's diabetes? It's a chronic metabolic disease where you've got high blood glucose, either because the body doesn't produce enough insulin or the cells don't really respond properly to the insulin that the body's producing. And insulin itself is the hormone that makes glucose from the food that we get. So it gets into the cells so that we could use it for energy. Now, when this process gets disrupted, though, the glucose builds up in the bloodstream, leading to various health conditions over time. And there are symptoms such as fatigue and frequent urination, thirst, and blurry vision. The two main causes of diabetes are type 1. This is the autoimmune cause of diabetes mellitus, where the body immune system mistakenly attacks the pancreas and it prevents the cells from actually making insulin. So there's a lack of insulin production, and the pancreas is not making enough insulin to regulate glucose. And this image shows you that pictorially. About 10% of diabetes is due to type 1, mostly in children. For type 2, this is more in adults. This is really referring to insulin resistance or maybe not producing enough insulin, where the body doesn't really respond to the insulin that's actually produced, and it leads to dysregulated blood glucose occurring in about 95% of individuals with diabetes. And this image also shows you, so regardless of whether you have type 1 or type 2 diabetes, the end result is that you have excess glucose in the bloodstream, and that affects the cells themselves. But there are other types of diabetes. Did you know that there's type 3C diabetes, where you have damage to the pancreas, but it's not due to an autoimmune cause? It may be due to inflammation in the pancreas, such as in pancreatitis or cancer in the pancreas, or if the pancreas itself has been removed. And then there's latent autoimmune diabetes in adults. It's similar to type 1, but it occurs more slowly and typically gets diagnosed in individuals who are older, over age 30 or so. And there's maturity onset diabetes of the young. And these are inherited forms of diabetes that tends to run in families. And then there's neonatal diabetes. And as the term implies, it occurs in the newborn, tends to be genetic. And although it is rare, and about 50% of babies that develop or born with this neonatal diabetes, 50% of them, this will disappear. But the other 50%, it actually can be permanent. And then there's brittle diabetes. And some of you may have heard about brittle diabetes. It's a form of type 1 that's where you have very frequent, severe episodes of high blood glucose or low blood glucose. And these are the types of individuals who would benefit from a pancreatic transplant. So in making the diagnosis then of diabetes, it's usually from your blood test, where if it's a fasting blood glucose, the glucose level would be 126 or higher milligrams per deciliter. If it's a random blood glucose test, it would be 200 or higher. And you look at the A1C, which gives you an average of your glucose level, maybe over about 30 days or so, and is 6.5% or higher. And these are the ways we can make a diagnosis of diabetes. What about high blood pressure or hypertension? This is really where the blood is pushing against the blood vessels. That's really the mechanism of high blood pressure. Normal blood pressure is 120 over 80, regardless of where you are, whether you're, disease or stage of kidney disease. High blood pressure is 130 over 80 or higher. And for many, there are no symptoms of high blood pressure until maybe something pretty serious is occurring, or you go to your doctor and they measure your blood pressure consistently it's elevated. Um, and then there are categories of hypertension. Normal, as I mentioned, is less than 120 over 80. It becomes elevated when it's between 120 to 130 over 80 to 90. And stage one is where it's high in the range of 130 to 139 over 80 to 89. Stage two hypertension is where the blood pressure is 140 over 90 or greater. And the image on the right shows you, when you go to your doctor and they ask you about your blood pressure and you give them those two numbers, that's systolic blood pressure. That really represents when the heart is contracting, right? Forcing the blood against the blood vessels. That diastolic is when the heart is resting. I think the important thing here to also note is that top number, that systolic number, really is the number that you want to focus on to maintain really good control. That's the number that will contribute to many of the complications that we see in high blood pressure. And there are two main types of hypertension: primary hypertension, where there are multiple causes. That's where most individuals have primary hypertension. Sometimes it's called idiopathic or essential or benign hypertension. And trust me, there's nothing benign about having hypertension. Secondary hypertension is where there's a specific identifiable cause of having high blood pressure, and most cases of secondary hypertension can be treated. So if you have high blood pressure and it's deemed to have to be secondary, typically there's a cause that can be treated. So why then is hypertension called the silent killer? And I'm sure that you've heard of this term. I don't really like the term, but it's actually real. And it's real because when you have high blood pressure, really there are no obvious symptoms. Most people with hypertension don't experience any noticeable symptoms, particularly in the early stages. And then continually, there are the damage that occurs in your blood vessels, very subtle over time. Even if there aren't any symptoms, the blood pressure, the high blood pressure, will consistently damage the blood vessels and damage the organs, so particularly your heart, the kidneys, and the brain. And with hypertension, it increases the risk of serious complications. That's some of which we've mentioned. And unfortunately, because hypertension is pretty much asymptomatic unless it's really, really high and you're running into trouble, it often goes undiagnosed. And so you want to be sure that when you go to your doctor's office, they're checking your blood pressure and that they're actually measuring it correctly. And I'll show you how that's done. Some of the risk factors for diabetes, I'm just going to run down the list here. Being overweight or obese, smoking, older age, particularly for type 2 diabetes. If you're over age 45, it increases the risk. It runs in families. It's also, there's an increase for diabetes for individuals who belong to racial ethnic minority groups. If you're physically inactive, it increases your risk. And there's also gestational diabetes. If anyone has gestational diabetes, it actually increases the risk of diabetes subsequently. Polycystic ovary syndrome, as well as prediabetes and non-alcoholic fatty liver, as well as some medications. Particularly if you're a transplant patient, you may be very familiar with steroids, prednisone being given to suppress your immune system. That can actually lead to diabetes and increasing your blood glucose. Some of the other risk factors for hypertension, and these are underlined because they're common to both, right? Family history, smoking, obesity, older age, racial ethnic minority groups, physical inactivity, eating a high sodium diet, more than half a teaspoon of sodium per day. And I think I laugh whenever I say half a teaspoon because I know in the United States, we're actually eating a lot more sodium. And for those who have hypertension, that's probably one of the things that your doctor or a physician would stress for us to reduce. Excessive alcohol consumption, reduced nephron number. Now that refers, the nephron is a filtering unit within the kidney. And for individuals who are born prematurely, there's just not sufficient time to develop all of the nephrons or filtering units. So having a lower number of nephrons puts an individual at risk for kidney disease and hypertension. And then chronic conditions, as we've mentioned. Hypertension, as many of you know, it can not only cause kidney disease, but kidney disease itself over time can actually lead to hypertension. Some of the symptoms of diabetes are shown here: increased thirst, slow healing cuts and sores, fatigue, blurred vision, frequent urination, and unexplained weight loss. Some of the common symptoms of hypertension are nosebleeds, blurry vision, dizziness, headaches, chest pain that, if it's pretty advanced, it's been long standing, where you can actually really impact the heart and cardiac function. Palpitations, as well as shortness of breath for an individual who has, pulmonary disease as a result of chronic hypertension and heart disease, and even blood in the urine. So this slide, I really wanted to go over with you, particularly for this audience, because it shows the continuum of chronic kidney disease progression over time, regardless of the cause, right? So initially, you must be screened for chronic kidney disease. We've gone over the risk factors, primarily because early in chronic kidney disease, there really aren't any symptoms. The symptoms only begin much later in the course of the disease. And with increased risk, there's the risk of damage to the kidneys. And then we really need to make a diagnosis with a blood test and a urine test. And that blood test allows us to measure our glomerular filtration rate, or EGFR, an estimate of the way the kidneys filter the blood. And that allows us to stage chronic kidney disease into 5 stages so that we could monitor progression over time. And over time, with chronic progression, it can lead to kidney failure, where you need either dialysis or transplantation. And then death, patients with advanced chronic kidney disease can also have early death, premature compared to healthy individuals. So we really want to do our best to acknowledge what we know and to prevent progression of chronic kidney disease over time, so that we can prevent that progression and premature death. I'm hoping that many of you have seen this diagram before. If you haven't, this is really a good time to understand what this is. It really allows us to classify chronic kidney disease based on the stages 1 through 5. That's based on that EGFR number that I mentioned, with kidney failure where the EGFR is less than 15, and normal function is where that EGFR is 90 or greater. And in addition to the EGFR, that urine test that your doctor may ask you for allows us to measure urine albumin to creatinine ratio, and it puts it into different categories, either normal to mildly increase, moderately increase, or severely increase. So what you see here in this grid, it's color-coded, and as you move from the upper left hand to the lower right hand, it really shows you the progression of kidney disease over time. So if you're in the green area, you're at low risk, essentially, for progression. Individuals where their EGFR and their UACR fall within the yellow area, those individuals are at moderately increased risk for progression of chronic kidney disease. And then worse for those who are in the orange zone, and of course, even more advanced progression for chronic kidney disease if you fall into the red zone. And I always like to show this, because by knowing this, by you're able to, look at your numbers, right? Your EGFR and your UACR, and follow it over time to see where you are. If you're in chronic kidney disease, one of the earliest stages, you want to monitor this very, very closely. For those individuals who have a kidney transplant, also it's important to monitor your EGFR and UACR. So why are we really talking about diabetes and hypertension? This what we call that dangerous duo. Because with diabetes, it's stiffening the arteries, and high blood pressure is really putting a big strain on the heart. And together, they speed up damage to all of those important organs. And where the kidneys are concerned, they promote faster damage to the kidneys. So let's look and see what it looks like. Here you see an individual. Most individuals have two kidneys. Turns out that some individuals are actually born with only one kidney. But you won't know unless there's an imaging procedure that's done maybe for a different or non-kidney related issue. And then it's obvious that you may have one kidney. And for those individuals who've been transplanted, you know that you can survive on one kidney. And the individual who's donated that kidney to you can also do well. And so, talking about those nephrons, right? Those filtering units, this diagram shows that very, very clearly. You see it, the cross section of the kidney, and you see that little bulb here. That's called the glomerulus. That's where the blood gets filtered, and the filtrate actually goes down these tubules and makes urine where you can excrete it via the ureter. So as I mentioned earlier, these filtering units are really important. We actually have about 1 million of these in each kidney. For individuals who may be born prematurely, we have fewer than 1 million, and these are the filtering units that we're protecting, right? Um, and so with diabetes and hypertension, over the long term, it can lead to this scarring within that bulb, that glomerulus, as well as within the tubules. And this shows you a picture for those of you who may have had a kidney biopsy. When you look at it at the high magnification under the microscope, the tissue would look pretty healthy, right? You see, this is the glob here, that glomerulus, and this is the cross section of all the tubules. And that actually is what it should look like healthily. But when the kidneys have failed, or when they're failing, there's this scarring. And so these the glomeruli, where the blood should be filtered, are so scarred down that they prevent the blood from being filtered. And the kidney really becomes very, very damaged, as you can see here. So what are the things that you can do? Well, monitor your blood glucose and your blood pressure regularly. Know your numbers. Know that your A1C, your target should be less than 7. And your blood pressure, you want to target less than 130/80. So you want to check your numbers regularly. And I really recommend that these are recorded and to take action as early as possible. Early action leads to fewer complications. How to measure your blood glucose? Typically, there's a blood glucose meter, as is shown here, with test strips where you can prick your finger to expel a drop of blood and put it on the test strip, and then place it in the meter to find that blood glucose level. Or more commonly, we're using continuous glucose monitoring to measure your glucose on a more consistent, continuous level. And you can see the number on your iPhone or your um, electronic device. I want to spend a little bit of time on how to measure your blood pressure accurately. And this needs to be done for individuals who have chronic kidney disease, you have diabetes, hypertension. Measuring your blood pressure and measuring it correctly is really, really important. And I'm talking about measuring it at home. And I recommend this very often. You want to make sure that you're using a validated monitor. There are lots of monitors out there. Not all of them are validated. There's one that I recommend often to my patients, but you can go to this website and I try to identify the monitors that are validated. So to measure your blood pressure, the best way to do it on a regular basis is early in the morning, right after waking up. You go to the bathroom, and come back, and you want to be seated for about 5 to 10 minutes. So it's a seated blood pressure. Your back should be supported with both feet on the floor, and your arm is at the level of your heart. And you want to use the correct cuff size. And this is, I put this here so that you can, take a bit of time for you to write this down to make sure that you are using the right size cuff for measuring your blood pressure with the monitor, right? So if you're a really tiny person, and this is the circumference of your upper arm around the mid in between your elbow and your shoulder. For small arms, excuse me, the cuff should be 20. The size of the cuff is use a small cuff if the circumference is 20 to 25 centimeters. Use a regular size cuff if it's between 25 and 32 centimeters. And a large cuff, it's between 32 and 40 centimeters. And an extra large cuff if it's between 40 to 55 centimeters. So typically when you purchase a blood pressure monitor, it may come with a regular size cuff, and you may need to purchase the appropriate size from the manufacturer or separately. And then you record your values and bring them into the clinic so the physician can monitor them. And so that you can monitor them, and it reinforces the things that you're doing. So some of those things that you want to do to delay progression or the development of diabetes and hypertension, you want to eat smart. We just heard someone talking about what to eat. Exercise regularly if possible. Choose water. We can talk about how much water you should be drinking. Want to get good sleep, good solid restful sleep, and of course take your medications on time. For individuals who've had a kidney transplant, for those individuals who are in advanced stages of chronic kidney disease, especially, you have to take your medications on time. And I'd love to talk to you a little bit more about why that's important. In terms of eating smart, you can limit salt, sugar, and fried foods. You want to eat balanced meals with non-starchy vegetables, whole grains, lean proteins, particularly plant proteins for those with kidney disease, and healthy fats. You can use the plate method where most of the plate is vegetables and less is made up of protein or carbs. And use the simple swap examples, like swap for brown rice instead of white rice, and baked foods instead of fried foods, and then drinking water. Importantly, read the labels and control portions, and of course, quit smoking. And then keep moving, right? The National Kidney Foundation recommends 150 minutes per week of moderate activity. And you could break that down to about 30 minutes per day of some type of aerobic activity, walking, dancing, biking, swimming, etc. And you can break it down into 10-minute chunks. You don't have to do it all at once. And start small, like 10-minute walks, chair exercises, but aim to also include strength training maybe 2 to 3 times per week. Um, and the reason why this is important is because exercise lowers your blood pressure and your blood sugar. So this is another really great slide, a diagram that shows you the impact of these lifestyle modifications on blood pressure. And what you see here is for each of these, like stress reduction, physical activity, sodium restriction, weight loss, tobacco cessation, moderate alcohol use, all have been associated with decreases in blood pressure, as is shown here. And then eating a DASH diet that's high in greens, vegetables, fruits, nuts, etc. That's really recommended to really reduce blood pressure and to promote overall health. And I show this slide because I know several of you may be familiar with some of the classes of blood pressure medications that you might be taking, like angiotensin converting enzyme inhibitors or ACE inhibitors, angiotensin 2 receptor blockers or ARBs, beta blockers, calcium channel blockers, diuretics to maintain and to really manage your fluid retention, alpha blockers, alpha 2 receptor agonists, as well as combined alpha and beta blockers and vasodilators. And more recently, a number of newer therapies have been added to therapies that have been around for at least two decades or so. And these include the SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, and GLP-1 receptor agonists. And these are all recommended on top of renin-angiotensin system blockers like ACE inhibitors and angiotensin receptor blockers on top of lifestyle modification. And then know that you're not alone. You have your primary care team, pharmacists, the nutritionists, are all individuals that you can reach out to assist with managing these conditions. And you want to ask questions and bring a support person whenever you go to your physician. And so here lists a number of resources that can provide additional information related to the management of diabetes and high blood pressure, as well as chronic kidney disease. And the websites are listed here, and I've listed the Renal Support Network. This is an important source of information, as you're all aware. So with that, I'm going to stop sharing and we can have a discussion. Are there any questions? I think maybe let's look at the chat. Okay.
I'll go.
All right. All right. So, you can raise your electronic hand or your physical hand. I think Cheyenne, I saw your hand, and Jim, you may have a question. So Cheyenne?
Yes, hi. Thank you so much for coming and talking. I have a question. I'm 29 years old and I'm a little bit worried about having diabetes. I do drink a lot of sugar, not much exercise, but I am trying to exercise as much. What are some preventative ways that I can not have diabetes at the age of 30?
Yeah, so you're right. I mean, does it run in your family, if you don't mind saying?
No.
No, okay. Well, we talked about some of the risk factors, right, for leading to diabetes, and certainly physical inactivity. So you want to do the best that you can. And like I said, you can start small, 10-minute walks. So start moving, as much as possible. That causes your muscles to really work better to respond to the insulin that you're producing. And that lowers your risk of diabetes. And one of the things that you mentioned at the very onset is that you drink a lot of sugar. Now, I think what you want to think about is how can you lower the amount of sugar that you're taking in, right? So if there are high, high sugar drinks that you like, can you switch to something that maybe doesn't have as much sugar? Can you maybe drink more water, right, than some of the high sugar drinks? Think about that, right? I usually recommend in terms of fluid, and I call it fluid intake that includes water consumption, to drink about a liter to a liter and a half per day. And the way that I would suggest it is, we all walk around with water bottles, right? And so figure out what a liter and a half of fluids might look like, pour it out, and then you can tell yourself, okay, if I drink a glass of, my favorite drink, flavored water or something at breakfast, maybe about a full glass would be about 8 ounces. And then at lunch, and then at dinner, that's, already a liter and a half. And then you could drink in between to make it 2 liters. So what I do myself is I walk with water in my car, in the trunk of my car. So when I get out of my car, I grab a bottle and I go take it with me, and I'm always sipping and drinking. Actually, I have a liter of water right with me. And I take this to clinic with me as well to show patients, that it's important to really know how much to drink. I hope that helps you, Cheyenne.
Yes, thank you.
Great. And what you can do is write down the best way to help yourself is to write down what you're eating and drinking every day. And when you realize that you're eating a lot of chocolate and other things on a regular basis, you're less likely to eat it because you're going to have to write it down, right? So think about incorporating some of those strategies. Jim?
Yeah. high blood pressure is what caused all my issues. It come from sleep apnea, which I found out later actually at dialysis. My dialysis nurse said you got to do a favor and take the test. And I wasn't breathing more than I was in the hour, so it was pretty severe. And I got controlled with 5 lisinopril, 5 or 10, and one of the other ones. But after I had a transplant deceased, the kidney was damaged pretty good. I started out with an EGFR 24 after transplant. Now I'm on massive amounts of calcium blockers. I'm on carvedilol, flodipine, and clonidine, like pretty much as high as you can go. And I just must not take to them, I guess, as much or whatnot, because I was always real good. They told me later on that you can't go back to the Citalopram on that because the kidney was damaged so much. They kind of hid that from me for the first part, telling me I was doing okay. But I wonder, I'm in line to get another transplant from a living donor now. Like, is it possible, like, the blood pressure can just level itself out from that kidney, and probably I could go back to the other blood pressures that maybe work, after transplant.
So thank you very much for telling us about, what you've been experiencing, Jim. But you raised something that's actually not too uncommon. And one of them is really getting good control of your blood pressure, right? The way that you can help also is to make sure that you're monitoring your blood pressure on a regular basis. I recommend every morning and writing it down. And what that does for you is it reinforces that you need to take your medications, the combination that you're currently on, the same way, the same time every day. The thing is that the medications that you're taking for blood pressure, for any condition, it needs to be at a certain level within your blood. And the way that it gets to that level, we call it steady state level, is by taking the medication regularly. If it's once a day, take it once a day. If it's every morning, take it every morning around the same time. Because when you don't do that, you lose that control. And then you're starting all over again where the blood level is low and you have to try to get up to steady state. So taking your your medications, blood pressure medications regularly every day, the way you're supposed to take it, and then measuring, and I showed you how to do it the right way, measuring your blood pressure and recording the numbers and taking that list to your doctor so that they can see what your numbers are running, and then they can adjust your medications accordingly to get to that goal, to get it under 140 and possibly under 130. Does that help you?
Yeah, I do all that. Like I'm just
Excellent.
do everything as much as I can, but I learned the lesson the hard way. Like I do the workouts, I watch everything I eat, no salt, no everything. Like I definitely keep track of it. But it's just crazy since this kidney came in. Like before I'm end stage, a little bit of the Citalopram stuff kept me great. Now, this kid at least I'm at an EGFR 2019 like that, and man, it's just the other blood pressure. I just assume they just don't work well. I follow my diet.
Well, yeah, I mean, there are many classes of blood pressure medications now. It's about getting the right combination. Okay, and it can be done. Trust me. I see patients with resistant hypertension all the time, and it definitely can be done. So just work with your doctors to get it under control and continue doing all the things that you're doing right now. And if your EGFR can stay in the low 20s, that's good, right? So good luck to you. Alan, your hand is up. You can
Yes.
put your camera on and let's hear your question.
Okay.
There
My
you
name is
are.
my name is Alan Haynes. I'm from the tiny island of Barbados. I'm a dialysis patient for over 9 years. I also had a sister who had a transplant that lasted 45 years. Okay. My question today, I used to suffer from hypertension, but now that I am on dialysis, I have the opposite thing. My pressure is normally pretty good when I start dialysis, but during dialysis, it tends to drop. There are two opinions. One says that you should eat, that you can eat during dialysis, and the other one says that you shouldn't eat. And I'm not too sure which one is the correct one. I've tried both, and my pressure still continues to drop. And sometimes the treatment has to be terminated because the pressure is so low.
Yeah.
First, you take off the UF, stop the UF first of all, And then sometimes I actually have to stop the treatment because I do not take any high blood pressure medication anymore.
Excellent. Yeah. So yeah, I mean, you actually raise a point that does happen, and mind you, I just want to also mention that I am actually from the Caribbean. I'm from Trinidad, so I'm very familiar
Okay.
with Barbados. It's close to
Okay. Yes.
and I'm going to be visiting actually next month. So I'll be thinking about you as we fly home.
Yeah, you could pass through Barbados. You can always give me a shout. Okay.
Exactly. But anyway, yeah, this is an issue that can happen during dialysis, and it's all related to the volume, intravascular volume, and it's regulating that intravascular volume. Remember, I mentioned that hypertension is where the blood pressure pushes against the blood vessels. Well, low blood pressure, which is what you're experiencing, is when the blood volume is so low that everything tends to collapse and you become hypotensive, right? And so there are certainly different ways to manage that intradialytic hypotension. And I think your doctor just needs to try different ways. And maybe they're taking too much fluid off. That could be one of them. And so if you're not maintaining your intravascular volume, or if you're maybe drinking a lot of fluids and having a lot of edema and they're trying to get rid of all of that fluid, it might be just a little bit too quickly, and it may cause that blood pressure to fall during dialysis. So they need to stop the ultrafiltration and to sort of help your blood pressure to manage. So the right thing to do is not take any blood pressure medications that could exacerbate that condition.
And I tend to play with the dry weight a little bit, increase it a little, etc. So anyhow,
Yeah.
thank you for your comments,
Sure.
ma'am.
Absolutely.
Dr. Nicholas, thank you so much for your
Absolutely.
expertise and your advice and your care and, just talking and answering the patient's questions here today. We really appreciate it, and we would love to have you come back another time and speak.
I'd be
You're
happy
just
to.
a wealth of knowledge, and I just can't hear enough of you. So thank you again for coming today.
Yes, thanks, Cher. Take care, everyone. Have a great Sunday.